Now we're going to be talking about seizures. A seizure, or what's colloquially known as a fit, is a brief episode of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. Your neurons are discharging, are firing, are activated in an abnormal way, excessively in an abnormal way. And the outward manifestation of this seizure will vary from uncontrolled jerking movements, which is called tonic-clonic seizure, to as subtle as momentary loss of awareness, as in absence seizure. Diseases of the brain characterized by an enduring predisposition to generate epileptic seizures are collectively called epilepsy. Usually, epilepsy, especially idiopathic epilepsy, is whenever you cannot find a cause for this seizure, then we're gonna just call it epilepsy. So epilepsy is you cannot find an identifiable cause, and you will find some EEG changes, some electroencephalogram changes. Seizures can also occur in people who do not have epilepsy for various reasons. What are the reasons that can cause seizures? And literally, they are everything. Literally, they are everything from brain trauma, drug use, elevated body temperature, hypoglycemia, low blood sugar levels, hypoxia, low levels of oxygen to the brain. And a first seizure generally does not require long-term treatment. Long-term treatment is only indicated when there is more than one seizure. Unless there is a specific problem on either EEG or brain imaging, then you will have to treat. We can classify the types of seizures into two big categories. Seizures that are accompanied with outward muscular movements, convulsive seizures, and seizures that are called absence seizures, where you do not see any outward manifestation. You do not see all these tonic-clonic convulsions, and we call it non-convulsive seizure, and this accounts for only 40% of seizures. Back to the convulsive seizures, which comprise 60% of the seizures. 2/3 of them begin as focal seizures in one localized part of the body, and then progresses and becomes generalized. And 1/3 will begin as generalized from the very beginning. The focal seizures are usually preceded by certain sensory experience known as aura. This could be sensory, visual, psychic, or olfactory, or even in taste, as we're going to see in today's case study. In a complex partial seizure, a person may appear confused. So don't forget, the word complex means some affection of awareness, some affection of consciousness. Jerking activity may start in specific muscle group and spread to surrounding muscles. So this is going to be called Jacksonian march, this particular pattern by which the focal seizure will proceed into being generalized. Unusual activities that are not occasionally, that are not consciously created may also occur, and these are known as automatism. Automatism is like the patient keeps keeps doing his tie or the button of the shirt. Automatism, repetitive, unusual activities. We have 6 main types of generalized seizures: tonic-clonic, myoclonic, absence, and atonic seizures. They all involve loss of consciousness. Generalized seizures will all involve loss of consciousness. The tonic-clonic, they present with contraction of the limbs followed by their extension, along with arching of the back for 10 to 30 seconds. Notice, most of the seizures will not last more than 5 minutes. Never more than 5 minutes. If they last more than 5 minutes, we call this condition status epilepticus. Status epilepticus lasts more than 5 minutes. So here in tonic-clonic seizures, you have it for only 30 seconds. And a cry may be heard due to contraction of the chest muscles pushing air out, and this is going to give this cry. The limbs then begin to shake in unison, and after shaking has stopped, it may take 10 to 30 minutes for the person to return to normal. And when the person comes to his awareness, he will remain a little bit confused for some time. Tonic seizures will produce constant contractions of the muscles, and the person may turn blue if breathing is impaired. Clonic seizures involve shaking of the limbs in unison. Myoclonic seizure involves spasms of muscles in either few areas or generalized through the body. In absent seizures, these are kind of the silent seizures. You cannot tell. There is no convulsions, and they may be subtle with only slight turn of the head or eye blinking, or maybe the patient is just staring and you don't know that the patient is not conscious. The person often does not fall over and may return to normal right after the seizure ends, though there may also be a period of post-ictal disorientation. Atonic seizures, where the patient suddenly loses the tone in the muscles, and this can lead to fall and typically occurs bilaterally. As for the clinical manifestations of seizures, as I said, for the duration, a seizure can last from few seconds to more than 5 minutes, at which point it's going to be known as status epilepticus. What's status epilepticus? A seizure that lasts for more than 5 minutes. Most tonic-clonic seizures last less than 2 or 3 minutes. Absent seizures are usually around 10 seconds in duration, and that's it. The post-ictal period. After the active portion of the seizure, there is typically a period of confusion called the post-ictal period before a normal level of consciousness returns. And here is an important point. How to differentiate between absent seizure and syncope, or how to differentiate between the post-ictal loss of consciousness and syncope. Syncope, the patient comes out of it, especially when it is due to a cardiac arrhythmias. The patient comes out of syncope induced by cardiac arrhythmias, comes out of it and returns back to normal, typically and totally normal. The patient is not going to take a period confused where he's going to be confused, but in post-ictal conditions, the patient will take some time. He will regain to consciousness gradually. He will be confused for some time, and he might be forgetful for some time, and then he regains full consciousness. Whereas when you recover from a syncope secondary to cardiac arrhythmia, the recovery is abrupt. For post-ictal syndrome, it usually lasts 3 to 15 minutes, but may last for hours. Other common symptoms include feeling tired, headache, difficulty speaking, and abnormal behavior. Psychosis after a seizure is relatively common, occurring in between 6 to 10% of people. Often people do not remember what occurred during this time. Very important thing. People do not remember what occurred during the time of seizure. For management of status epilepticus, actually this is what is agreed upon. Management of status epilepticus is more agreed upon than management of epilepsy itself. We have a lot of medications for epilepsy, and it's very hard to tell which one is the first choice and which one is the second choice. But as for status epilepticus, everyone agrees on you are going to start with benzodiazepines. Ativan, lorazepam for status epilepticus. A seizure lasts for more than 5 minutes, start with the benzodiazepine. If the seizure does not respond, then give phenytoin or fosphenytoin. If the seizure persists, then we can add phenobarbital, which is a barbiturate. And finally, if the seizure persists, we do not have any alternative but using general anesthetic like propofol. As I said, because seizures can be caused by a lot of causes, we have to exclude these causes before we diagnose the seizure as epilepsy. So we have to do electrolytes. And notice, sodium, whether hyponatremia or hypernatremia, is a major cause of seizures. Sodium, low sodium or high sodium will predispose to seizures. But also calcium disorders, magnesium disorders. So always get electrolyte test. Glucose and oxygen, because hypoglycemia can result in seizures. Hypoxia can result in seizure. Head CT, because any intracranial lesion, space-occupying lesion, hemorrhage, or tumor can result in seizure. And MRI also is indicated if the CT did not show anything. Urine toxicology screening, because a lot of medications can result in seizures. Liver and renal function are also needed. If the initial set of diagnostic tests do not reveal the etiology, then do an electroencephalogram, EEG. So if you don't have a cause and you have some positive findings in EEG, your diagnosis of seizure is going to be epilepsy. As I said, treatment of epilepsy is not universally agreed upon. And the chronic anti-epileptic therapy or long-term anti-epileptic therapy is usually not indicated after a single seizure. Except, when are you going to treat epilepsy or when are you going to treat seizure? After the first one. If there is a strong family history of seizure, if there is an abnormal EEG, if there is status, if the patient presents with status epilepticus that required benzodiazepines to stop the seizures, or non-correctable precipitating cause like brain tumor that's irresectable and you cannot take it out by surgery, then you have to give anti-epileptics to control these seizures. And usually the old drugs, the time-honored drugs, valproic acid, carbamazepine, phenytoin, will always be tried first, and then maybe we can also try gabapentin or phenobarbital. Ethoxamide is the best for absence or petit mal seizures, and valproic acid is the most dangerous one to be used in pregnancy.